Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Welcome to this week's episode of the Healing Pain Podcast. This week, we're discussing how to combine two evidence-based and effective methods for the treatment of chronic pain, which are cognitive functional therapy and acceptance and commitment therapy. My expert guest this week is Mary Grant. Mary is a senior physiotherapist at the Rheumatic and Musculoskeletal Disease Unit at Our Lady Hospice in Ireland, where she's developed extensive skills in musculoskeletal rehabilitation with a particular emphasis in arthritis and persistent pain problems. She is a guest lecturer at the University of College Dublin in the physiotherapy program, where she trains student physiotherapists on the assessment and treatment of arthritis and has been involved in the development of a new program with Arthritis Ireland. In addition to her physiotherapy degree, Mary's also earned a Master's of Manual Therapy and has a keen interest in combining pain neuroscience education, cognitive functional therapy, and acceptance and commitment therapy for the treatment of chronic pain. On today's episode, you'll learn about the similarities, differences, and complementary approaches of cognitive functional therapy and acceptance and commitment therapy, how they help people with persistent pain, and how physiotherapists can go about employing these methods and techniques in clinical practice. And if you're interested in learning more about acceptance and commitment therapy and how you combine it with either pain neuroscience education or cognitive functional therapy, make sure to check out my latest book, Radical Relief, A Guide to Overcome Chronic Pain, which is available on Amazon. Inside, you'll learn all about ACT, or acceptance and commitment therapy, and how you can combine it with pain neuroscience education. Okay, let's get ready and let's meet Mary Grant and learn about combining cognitive functional therapy with acceptance and commitment therapy. Hey there, Mary. Thanks for joining me this week. I'm excited to talk to you.
Hi, Joe. Thanks for having me. I'm excited too.
Mary, you're one of the few therapists I know that are doing really great work with generalizing a couple of different approaches with pain, with regard to pain. And that's pain education or pain neuroscience education, cognitive functional therapy, and now acceptance and commitment therapy. And I love this, and I want to see more professionals start to implement this kind of knowledge and weave it all together, because they're all important. They're all effective in some either small or large way. But the challenge is getting people to, kind of bring this all together. So I think your story is so important, because it really is a story of someone who's been on an exploration to learn more about pain, which all of us are on as professionals. And of course, people with pain are on that same explanation, that same journey, that same path as well. Just kind of give us the 10,000 foot view of, you've been practicing since 1990, kind of start us a little bit way back then, so to speak, and then bring us to kind of where you are today.
Okay, sure. Yeah, I qualified in 1990. That's quite a while ago. And starting off then, like a lot of young physios, just did lots of different rotations around general hospitals. Enjoyed all of that. Then really felt I wanted to do MSK, which is kind of hard to get into to specialize in, really. I was lucky enough to get a job in a rheumatology specialist unit at that stage. And then I started doing loads and loads of courses, lots of different MSK courses. The caseload in the place I was working, and I still work there, it's very varied. Lots of patients presenting with complex persistent pain. So it's really fascinating, but really challenging work at the same time. And I was kind of looking for the answers to trying to find the best way or the best combination of ways to work with these kinds of patients. And manual therapy was kind of the holy grail at the time. Muscle imbalance and those kind of courses were out as well. And then pain neuroscience was coming online as well. So I just did all those courses, like lots of physios at that stage, I think. And in 2010, I did a master's in manual therapy. And I thought at that time, this has to be a holy grail. Like, this is the pinnacle of learning in MSK. And surely I'll have all the answers now after I've done all this. I'll know exactly how to treat persistent pain.
Yeah, it's funny. As I listen to you, your career mirrors mine a lot. We both graduated in the 90s. And, back then there was a really strong emphasis on manual therapy and exercise as well.
Yeah.
But then slowly, kind of like mid 90s, started to creep in some of the pain education. And
Yeah.
it really did start out slowly. I mean, now pain education, pain neuroscience education, explain pain is this big thing. But I think all of us remember when there were just little bits and pieces of, and many of us were putting those pieces together even before those frameworks and the research was out there.
Yeah, that's right. But there wasn't really like a way of how you put it all together. Like you'd be doing your manual therapy bit to somebody, and then somehow you'd try and throw in the pain bit. Then there'd be some really specific exercise you'd be putting in there too, like that was so hard that like nobody could do.
Yeah.
So a lot of it didn't really make any sense when you tried to put it together, it seemed to me anyway.
So the manual therapy degree didn't kind of top off wasn't the icing on the cake for you?
No, it wasn't.
So when did you start studying, or how did you come about cognitive functional therapy?
Yeah, so a couple of years after doing the master's in manual therapy and trying really, really hard to develop the magic cans and work really hard on that, I was just getting really fed up and really disillusioned. And I'd obviously seen Peter O'Sullivan's work on cognitive functional therapy out there. So I went to a workshop in London in 2014, and it was amazing. It was a real revelation at the time. It was just best workshop I'd been to, and there were lots of other physios like us with a similar experience, having done lots of different courses, trying to find, answers and how best to manage complex persistent pain. And it was just a really nice kind of coming together of people. Yeah.
And I want you to define what cognitive functional therapy is for us in a moment. But just before that, did you start to venture into that CFT space? Of course, it's new and evidence-based, but was that because you found that pain education, like the manual therapy, wasn't what you thought it was?
Yeah, it was all, well, obviously there's fantastic science behind it, but it seemed like you had to give the patient all this information and they were supposed to take it on, and then suddenly everything would make sense to them and they'd be able to do what they wanted. And it just didn't work like that. It just didn't. So yeah, the CFT, what was so good about that was it was really more about, working with the person where they are in their journey as such, and not like spewing all this information at them, but kind of going, okay, let's make sense of your pain problem together, because you probably have all the pieces of the puzzle. And let's just see, can we try and put those pieces together in a way that makes sense to you?
I like that. So it's really helping the patient build that story of what happened around their pain, versus pain education is kind of, I'm going to deliver you this information and here's all the info, and with that you'll change.
Yeah. Exactly. So that's the big difference. And that, like, you'd have patients saying, yeah, I get what you're saying. I understand this pain doesn't mean harm thing or doesn't equal harm. Yeah, but my pain is different, or my pain is not like the other person's pain in the group that you're talking to about pain. So it just didn't make sense to them. So, you really have to make it individual. And that was what was different about CFT, was very much that person, what was going on with them at the time that they developed the pain problem, what might be still going on that's keeping that pain problem going. Very different that way, I felt.
Right. And I think what you're saying is reflected in the literature, that pain education is one small part of a cognitive behavioral and lifestyle approach to helping people with pain. So like you said, it's not the holy grail, just like manual therapy is not the holy grail. We have to learn how to use it effectively and efficiently, but it's a smaller part of that bigger process that people will go through with regard to pain. Let's dive into cognitive functional therapy a little bit. And that as a treatment model is still being built out by Peter O'Sullivan and J.P. Canero, and other wonderful physiotherapists who I admire and follow their work. Just in your own words, because I know you've been through some training, define for us what cognitive functional therapy is.
Okay, so Yeah, I haven't done any formal training in CFT, just want to say that. I've been to quite a few workshops, which were brilliant, but there is some research underway about what formal training would entail. So to say that, I'm not an expert, but I think CFT is a framework where you can apply the biopsychosocial model, and it's truly patient-centered. So you can apply it in this patient-centered way, in an individual way. And it's underpinned by open communication, which helps to build trust and good therapeutic alliance. That's really at the center of it. And it's really then about looking at what movements or activities the patient avoids or fears, or the ones they find are provocative for their pain within all of that. And you look at those as a behavior experiment. So you're looking for things that you can pull out of how they move or what they think about how they're moving, and see, can you maybe give them a different way of doing it.
Excellent. A lot of it centers around lower back pain, right?
Yeah, but they use that model and they're expanding it out now in the research way as well in other areas of the body too. So it is something that I certainly use it with all of my patients, or I try to use that approach with all of my patients. The research is mainly in low back pain, yeah, but JP Canero, actually, he's working on OA knees and OA in general at the moment, doing quite a bit of work in that space. So, yeah. So it is expanding all the time.
Yeah. And I've had both JP and Peter on the podcast. Everyone can go back and find their episodes, and we'll link to that in the show notes. But you're right. Kind of started out with chronic lower back pain, and now they've moved over into knee osteoarthritis, which is useful and beneficial. So I'm just curious. So you use CFT in practice right now. You've done some workshops on it. You follow up on the research. Am I hearing that CFT was a game changer for you? And if it was, how come you still kind of brought ACT into your treatment?
Yeah, that's interesting. I think there's a lot of similarities between CFT and ACT. With CFT, you're explicitly targeting pain control during exposure to the nominated tasks that the patient say are difficult for them. But the whole idea is you're challenging kind of negative, what they call negative and inaccurate cognitions, and modifying how the person physically performs the task using body relaxation, body control, and extinction of safety behavior. So that's kind of the hook, that's the way in with the patient. The problem then can be if you have a patient with pain that moves well and they don't have any of those, I suppose, movement behaviors or safety behaviors that you can change. There isn't a hook that you can really grab onto. And I kind of was struggling with those kinds of patients, and there's plenty of them. And then there's also the patient where you do work through those kind of movement behaviors and they successfully integrate the new ways of moving, but they're still really bothered by pain. So they're saying, yeah, I could see I'm moving better, but the pain's still really, really annoying me and it's there all the time. So what to do to help that person? And then I started noticing psychological flexibility being mentioned in social media, and as well in the RCTs and CFT, they found that psychological flexibility was particularly important in determining responders to CFT. That kind of, I was thinking, I've heard that before, I've seen it somewhere else. And then there was a few podcasts around your own Healing Pain podcast, Joe, and then another really good one from Australia, the Knowledge Exchange podcast. And they were talking about ACT. And it just seemed like this might really work really well with CFT. And then because I work in a rheumatology specialist unit, we still have lots of patients that have, I suppose, they're limited in terms of how they can move. It seemed as well that maybe something like ACT would be really useful for someone who has got impairments that they can't necessarily change. So that was really, what made me think maybe this would be something that could add to CFT. CFT is fantastic and it's the best framework I've come across. But maybe this was something that could add to it, is what I thought.
I love that, because what I like about that is you took something that was evidence-based, you learned about it, you implemented it into practice, and yeah, worked with some people, but it didn't work with others. And I like, you kind of broke that down to 3 parts. I think we should just highlight those just briefly.
Yeah, sure.
So CFT is, in essence, it helps people and it targets people who have movement dysfunction, and they're relying on safety behaviors to move.
Yes.
Right.
So fear is kind of driving that behavior.
That's right.
Pain has caused them to change their behavior. Beliefs about pain has caused them to change their behavior. And that's kind of, I suppose, at the hub of it in a way. You're trying to, this is what I understand about it anyway. You're looking for these maladaptive beliefs and you're trying to change those beliefs through changing their behavior.
That's right. And you found that worked with some people, and some people you would change the way they moved and you worked on their beliefs, but yet the pain persisted.
Yes. Yeah.
And there were some people who came in with those, what we call maladaptive beliefs, but had no movement dysfunction.
Yeah.
So you were thinking, okay, well, what do I do now?
Exactly. Because I didn't have a way in then. Really.
There was no way in.
Yeah. Or I didn't seem to have a kind of an option to offer those people.
So ACT was another tool and another way in to start to help people who pain neuroscience education or cognitive functional therapy may not have been going deep enough with them.
Yeah, I think that's fair to say that's the case. Yeah.
So tell us what this looks like. So, another journey now begins with you into ACT. And I know it's a journey kind of we're on together, so to speak. What did you notice as you started taking ACT and implementing it into your practice?
Well, the very first thing that kind of hit me in the face was my own really strong bias or professional identity towards needing to reduce pain. And I really wasn't aware of that. That was such a strong bias, just kept coming up all the time in the early days of learning about ACT. Like with CFT, I'd moved from doing manual therapy to the patient to relieve pain. I changed from doing that to working with the patient to find their own ways to reduce pain. So I had made a big shift in how I worked with patients, but my main goal was still pain reduction.
Right.
Yeah. And again, of course, like that's not wrong or bad or anything. And it really is how physio is viewed generally by physios, other healthcare professionals, and the general public. Physios help to ease your aches and pains. That's what we do, isn't it? And then, when you're talking about discussing patients or, asking patients how they're doing, like there's always this kind of subtext like, well, is it working? Which really means, is your pain gone? And often that just isn't possible. It's often not possible with persistent pain. We know that. Mm-hmm. So what I found with ACT is it really expands the options available to me on helping people to live well with pain. And that was, I thought I was doing that, but I wasn't. I was still trying to get rid of the pain. I could even think back to, sessions with patients where I would be doing all the movement adaptations and extinguishing all the safety behaviors. I'd be going, how does that feel? How does that feel? How does that feel? And if the patient wasn't saying better, or the pain is less, or the pain's gone, I'd be like, oh no, I should be sweating. So yeah, that was the big shock, I think. Yeah. That was what I was doing. I wasn't even aware that was what I was doing.
And that can really weigh heavy on us as professionals if we take on that role of someone who, one, has the ability to solve everyone's pain, or if we believe, talking about maladaptive or false beliefs, I think, of approaching our career and approaching our patients with, yes, I have the ability to wave my magic wand and take your pain away.
Yeah. So I'd moved from trying to get the magic hands but I was still trying to do magic in another way, I suppose.
Oh, I love that. So you
Yeah.
had magic hands, right? So
Well, I never really got the magic hands.
right.
I tried really hard, but it just never happens.
And touch can be a magical thing for people, right?
Yeah.
But if we approach it like, yes, with this certain approach, I'm going to work my magic, so to speak, that can be quite challenging. So I'm just curious, as you know, when you come into, my ACT training program, in the first week, I'm talking quite clearly about adopting a stance that is not about pain relief. That doesn't mean that an ACT approach does not alleviate pain. Many times it does. But there's definitely a group of people or patients where we're not quite sure what's going to happen. So we start off with that stance of not pain relief first.
Yeah.
Did you find that existed within the pain neuroscience education and cognitive functional therapy world?
Not putting pain relief first, you mean?
Yes, right. So did you find those two approaches were pain relief first, where ACT is pain relief might happen, but it's not a priority of our treatment?
Absolutely. I found that really difficult. I found that really confrontational at the start, I think, as you know, and everyone in the Facebook group knows, because I kept going on and on about it. I found it really, really hard to not have that as my main goal with every patient from the start. Yeah, really struggled with that idea of just stepping back from that as a goal. Because a lot of the patients, when they're coming, they're like desperate to have pain relief naturally enough. And they've, maybe you're, because of the particular, unit that I work in, they've been through maybe 4 or 5, maybe 10 different approaches already, and they've failed those, and that's weighing on them. And then we're like the last hope for them of what they see as they have to get rid of the pain to go on living, be able to live. So, yeah.
And what you experienced, I mean, I find this, depending on the professional who comes into the program, their background, their experience, their previous training, some people are really like locked in horns with pain relief. And it's hard for them to kind of let that go. I know when I first started learning mindfulness and acceptance-based approaches, and I've looked at all of them at this point, I really had to spend some time just reflecting back on my own work, reflecting back on things that I believe, reflecting back on things I've said to people, and look at, okay, was that appropriate? Could I have delivered it differently? And how do I now start to, move forward from this? And some people, can get it right pretty fast. And other people, again, if you've been through that biomedical training, manual therapy, pain neuroscience education, where we're going to reconceptualize and change all this, it can be really tough for people. So I appreciate you talking about that, because I think what you've experienced, many other people have, and to this day still do. They go into clinic every day and they actually struggle with this, because we know burnout is high amongst professionals who treat pain. So if you're trying to eliminate pain and it's not happening, and you're going home at night and you're stressed about yourself, or you feel like, how can I continue to serve people deeper? I recommend you explore that. How can you serve people deeper, but serve it from an acceptance-based perspective versus one of a complete reconceptualization perspective.
Yeah, which is very different.
That's extremely different.
Yeah.
It's really night and day in a lot of ways.
Yeah, for sure.
And they can coincide, and they can run what I call collinear. It's just that typically over time, what I tend to see people doing is pain education in the beginning, maybe the first, 1 or 2, maybe 3 sessions, and it's still there throughout, but moving more toward that acceptance and commitment therapy approach with regard to treatment. So tell us, how does ACT help people live with chronic pain better?
So, living well with pain is a really difficult concept, isn't it, for all of us, really, patients and clinicians. It doesn't sound right, living well with pain. So it's a tough one. I think the first step is to acknowledge the patient's journey to date, and what they've tried already to get rid of pain, and how this has worked or maybe not worked for them. Then what I love about ACT is using metaphors like storytelling to try and maybe help the patient to see that maybe there are other ways around this, that maybe it's okay to drop the whole trying to control the pain or get rid of the pain agenda, because that can be really hard for people, because of course that's what they want to do.
Yeah.
So I think that has to be, you have to kind of go carefully with that with people.
Yeah.
And then the next thing, I suppose, once you've kind of got that suggestion out there that maybe controlling the pain is not maybe the most beneficial way to go, maybe they're ready to try something new. And that's where I think clarifying what values are for them as humans, like what they care about most and who they care about most in their lives. So them as people. And that's, I think, the next big thing that can really help them to kind of go on the path towards going back to what they want to do or be. It's different.
And where do you find yourself bringing values in now that you have trained in ACT? Because if you look at the literature, some approaches put them first before anything. Some of the protocols put them kind of last once they've been trained in some of the psychological flexibility skills. Where do you find values coming up in your conversations with patients and your evaluation?
Usually pretty quickly, if not the first session, then maybe the second one.
Mm-hmm.
It's something that is done in CFT to an extent as well. So they use the concept of meaningful activities and getting back to your meaningful activities, which I think is quite similar, but maybe values is a bit broader in a way, because values is more of a compass rather than, goals. So obviously meaningful activities are really important and, can be part of values. But let's say, you have someone who really wants to be able to play football with their kids and they're struggling to do that. And that might be part of the value of being a good parent for that person.
Mm-hmm.
And playing football is just too much at this point in time. But you can also be a good parent by maybe reading a book with your kid or doing their homework with them, that kind of thing. So you can still work on their values with them, but still work towards maybe doing other stuff. So they're still being guided by their values, if you know what I mean?
Sure, yeah.
Yeah, which I think is really important, because you can get really bogged down in the, I can't do this thing now and I really want to, and that means I'm crap. So therefore I'm not going to do anything and I'm depressed and I'm, you know what I mean? Like, it's awful. So I think the beauty of ACT is kind of looking at all of the ways, or maybe the steps towards the thing that's guided by your values, which is a much bigger thing, and it's always there. You can choose to live by that. You can choose to maybe sit on the couch or go to bed because you're feeling really crap, or you can maybe decide, okay, I'm going to sit beside my kid and we're going to do some reading together. And that's values driven.
Yeah.
Yeah.
And I like that you mentioned the meaningful activity part from cognitive functional therapy, super important. And then ACT has values. And I always I have looked at those two like you have, and I'm like, well, meaningful activities is important. Values are important, but I kind of find like the values almost like turbocharge the meaningful activity, so to speak.
That's a really good way of putting it. It does, yeah.
Yeah. Because sometimes people don't quite, I'd like to do meaningful activities, but I'm still in pain.
Yes.
So the values some way kind of like circumvents that, or kind of gets around it in what I call a sneaky way.
Or they don't even really know what you mean when you ask them, what are you missing, or what do you want to get back to? They're not even able to say what that is, because they've been immersed in the whole awfulness of the pain for so long, and it's really hard for them. They can't even say what it is. It's been so long since they've been able to do things that they enjoy or were interested in, or they don't even know anymore. So I think it's that values piece, and giving time to it is a really nice way of allowing them to kind of think, what do I want? I'm not just a person with pain. I can be a person who's interested in things or wants to do other stuff, not even the doing, but not just be a person with pain. because your
That's
world gets
interesting.
really small. Yeah.
I've never actually thought of it or looked at it like that. So really what you're saying is it's hard for them to contact meaningful activity because pain in essence has stripped the meaning from their lives,
Yeah.
which actually points to experiential avoidance.
Yes, that's right.
Right. So you're
Yeah.
trying to have people contact meaningful activity, but they're so experiential avoidant and so fused with what's happening that they have a hard time accessing that. But values can be a way to bring them back around.
Yes.
Mm,
That's lovely. Yeah.
I like that. I like that.
Mm.
Good, Mary. We made a nice little connection there together. That's good. Describe to me how you work with thoughts and emotions, which are an important part of any approach to pain. But how has ACT helped you with the thought and emotions part of persistent pain?
Yeah, I've always kind of I'm going back to CFT again, and again, CFT is fantastic, and they do address things like thoughts and emotions, but it kind of, I don't think there's really a kind of a way of explicitly working with thoughts and emotions in CFT, and there is in ACT. Like you've tools to help people to notice what their thoughts are and how those thoughts are affecting them, so that you can explore how their mind is affecting them in terms of their pain with them, which is really interesting. So I suppose the first step is trying to focus on present moment awareness, isn't it? And so that they can try and notice what their thoughts and emotions are in the present moment when they're doing something that's maybe scary or painful or both. So that is really interesting, I think. Because often I think patients don't have an awareness that thoughts and emotions can have an effect on how they behave or how they move, or the pain, or effect on the pain, or that the pain itself generate thoughts and emotions, and vice versa. Thoughts and emotions generate the pain. Because that's new, really. It's new in a way, some ways to me as well, the whole thoughts bit power of it. And yeah, before learning about ACT, I would ask people what they were thinking about a feared task. And I'd see that they were struggling with something, I'd be saying, so what are your thoughts? And they might say, I'm really afraid that this is going to damage my knees. And I would try and reframe that thought or refute that thought, instead of maybe just stepping back from it a bit, letting them step back from it a bit, and allowing the thought to be there, but still go ahead and do the task that we were working on. So that's been a whole new way of working with thoughts for me with this pain. I think the way I was doing it by trying to refute or reframe thoughts was probably quite invalidating. And I didn't realize that it was. Or in my head, I'd almost be saying, I'd be almost wanting to say to the patient, just stop thinking that thought. That's just a silly thought. It's not real. It's not a fact. It's just a thought. So you can't, that's, now I don't think that's the right way to go, obviously. I think that would be really probably quite upsetting for people as well to have you say that. And then trying to deal with hypervigilance as well, because hypervigilance is so common in people who are struggling with persistent pain.
Yeah.
And obviously thoughts are a big part of that, the whole thinking about it all the time, or, and I used to ask patients, how much time do you spend thinking about your pain? And they might say, all the time. And I'd say, do you think how's that working for you? Or do you think that's a good thing to be doing? Almost with the suggestion that, you could just stop doing that. You could just stop. And I used to write that down as well on their little homework bits. Stop thinking about the pain. As if you could do that, as if that was possible. So I love the fact that in ACT, there are tools like cognitive diffusion, where when you have thoughts that are intrusive that keep coming up all the time, that you can show the patient that this is another way of dealing with these thoughts. This may help. You don't have to push them away. You don't have to block them out. You don't have to stop thinking them, which probably isn't going to work. You can try this instead.
Yeah. And everything you just explained, if people go back to the episode I did with Lillian Dindo, she's a psychologist who uses ACT in workshops, one-day workshops. And her and I talked briefly, not about this exact topic, but we talked briefly. Well, it was this exact topic. We talked about it briefly. And she said, look, she's like, if you start using traditional cognitive behavioral therapy, like you mentioned, helping people reframe their thoughts, and you start using ACT, you'll find that there's definitely a group of people that don't like to have their thoughts refuted because they know that these thoughts are quite persistent. It's almost like they're like, hey, I appreciate your help. I appreciate you helping me reframe or challenge these thoughts. But just so you know, these thoughts have been here a long time.
Yeah.
It's almost like, what else do you have? What else is in your bag or trick? Well, okay, here's cognitive diffusion. So if those thoughts are not going to go away, and all of us, like even if we just reflect on our own personal experience throughout life, not about chronic pain, just about things so everyone listening at home, just think about what type of thoughts do you have about yourself that have probably been there since you were young that constantly come up. They may not come up every day, but they come up during certain situations, around certain people, around certain times of the year. Have those thoughts gone away? And the answer is no. Yet, there are effective and evidence-based ways to relate differently to those thoughts so they don't negatively impact your pain.
Yeah, so you can allow the thought be there, but you can still move along in accordance with your values.
That's right.
What we were saying earlier. Yeah. So I think that's very powerful. That's really powerful for people.
Yeah.
I found it really helpful myself, just in my own life as well.
Tell me about that. Where have you started using some of these skills in your own life, and how have you found them to be beneficial? Because I'll tell you from personal experience, when I first learned ACT, I was excited to use it with patients, but I couldn't believe how it changed me.
Yeah. Just to give an example, and I suppose it's maybe a little bit superficial, but it's probably not actually either. So I do powerlifting as a sport, and I'm not sure if you're familiar with powerlifting. Yeah. Anyway, whenever I have to do like a max lift in training or on the platform in competition, like I just really scary. And I'd have the whole like heartbeat thing, hardly able to breathe, nausea, hands are all sweaty and everything. Even as I'm talking about it now, I'm starting to get a bit of that. And I used to try and push all that away, or I'd have my headphones on. I'd try to pretend I was somewhere else. If it was a competition, I think I was anywhere else but there. So I'd try to remove myself. And then on learning about ACT, I was thinking, I'm sure some of these techniques or all of these techniques would really help me with my whole squat fear or lifting heavy fear, which is a bit of a pain when you are supposed to lift heavy. And yeah, really did. Just even the whole noticing the thoughts bit, noticing what I was afraid of, and actually voicing that thought to myself, and then just letting them be there, connecting to breathing, noticing other things around me as well. So that whole present moment awareness bit, whereas before I'd be trying to block things out, and then I wouldn't execute the lift properly, or I'd miss a command in competition and I'd do a stupid mistake. So like I realized that wasn't working, and that this way of doing it, which obviously takes practice because I'm still practicing it, but it certainly works better for me, that being present was better, and being able to notice the thoughts and call out the thoughts, the familiar thoughts that would come up when I was afraid.
Every person who's trained in ACT has a story that relates to themselves.
Yeah.
And sometimes they're, just things related to exercise, like you're mentioning. And sometimes they're, other types of examples that are a little bit deeper for people. But I do think to effectively promote and use ACT, yes, you have to learn it. I think there's a process of understanding really what's happening. Like you mentioned, that shift that happens with regard to acceptance or willingness, as we like to say.
Yeah.
And then you apply that. So you learn it kind of didactically, then you apply it to your own life, and you continually apply it to your life throughout your life, because we all may have episodes of life that become challenging, that we'd like to kind of stiff arm and push away from us and not have, but yet we're going to be confronted by many different types of challenging things in life, some of them actually involving both physical and emotional pain, if we're even making that distinction anymore. I don't think we are.
Yeah.
And then, okay, how do I use this with people? How do I help people with it? Now, in your example, you mentioned fear, right? Fear came up. So when you reflect back on what you've learned about ACT, and then what you've learned about cognitive functional therapy related to fear and fear avoidance, do you see a distinction between those two, or how the approaches are distinct?
Yeah. Both ACT and CFT target fear related to pain. I think, if you look at Flahan's fear avoidance model, CFT works somewhat to extinguish fear, and ACT takes the stance that maybe we don't need to extinguish fear in order to recover, and maybe it's not always possible to fully extinguish fear. And I think that's true, having experienced that myself. I don't think it is possible to extinguish fear, but that you can still do what you want to do, but have the fear there. You almost have to acknowledge it. Well, not almost, you do have to acknowledge that it's there, know about what it feels like in your body as well, because there's the effect of fear on the body. So being aware of that instead of trying to block it out. I think that's a big difference between ACT and CFT, because I actually don't think it is possible to extinguish fear, especially when it's related to something like pain. Pain has a horrible way of kind of cropping back up again, and then the fear comes back really, really quickly. They're like first cousins, aren't they, really?
I like that. First cousins. That's a good way to look at it. Yep.
Yeah.
Some of the neuropsychological research really points to the idea that it's very difficult to what we call extinguish fear. Almost like we can take a fire extinguisher and kind of, spray some like powder on it and boo, the flame goes away.
Yeah.
Right? So like if you've ever had chronic pain, it can be very difficult to extinguish those thoughts and beliefs and even the fear about things that may cause you pain. And that makes sense because we know that pain is about prediction, right?
Yeah.
So the mind is predicting what's going to happen in an effort to protect yourself based on your personal learning history. Right? I said we talked about this week, actually, 3 Ps, right? Protection, prediction, and your personal learning history, how those 3 kind of come together. And I truly believe that it's almost impossible to extinguish that fear once someone has it. But like you said, that doesn't mean that we can't change the environment and place new memories on top of that fear that make it less impactful for us, which is really what ACT does. We help people relate differently. And through that relating, we develop new memories, not overriding, not extinguishing the old ones. They're still there. There's no delete button in the nervous system, but we're helping people relate differently. And with that, they create new memories and hopefully different behaviors they can now adopt and move forward, as you said, with different types of activities, which kind of starts to bring us to exposure, right?
Yeah, exactly.
Which is really, I really do think that's our specialty as physiotherapists.
Absolutely. What's different though with exposure and ACT is you're exposing people to the pain, not exposing people without pain. Well, just so far, like that's how I would have used exposure before ACT. I would have used exposure in a way of, let's go as far as it's comfortable for you today kind of way. Yeah. Even with CFT, and in fairness, I don't think that Peter O'Sullivan necessarily would do that. I think he's really fearless around pain, and and the CFT approach would encourage that. But I think ACT gives you a bit more of a permission to do that, because it's part of like you're exposing the person to what pain is like, and that's what they're learning, that it's okay to feel pain and do this thing, that the pain isn't, it is saying, you know, pain is not the same as harm all the time, but it's then experiencing that and everything that comes with it. And not just the physical sensations, but the thoughts and the emotions as well as part of that. Yeah, like, you know, when you ask, I had like a patient today, can you lift your arm up? And she's saying, I can go this far, but that's it. Go, what happens then? And what she meant, I can go this far without pain. Can you go further? What happens? And she could go further, and it wasn't maybe as bad as she thought it was going to be. There was pain, but she could do it. It was just an interesting, I only met this lady, it was her first session, but like, it was interesting for her that she's like, okay, so you're telling me, you're giving me permission to go past the pain. I think that seemed to be quite new for her. Whereas before, I think theme, like other interactions she would have had, would have been stop at the pain, don't go any further. And, you know, she was saying, oh, you mean I can go further than the pain? Which is was different.
Yeah. And it helps us relate differently to patients when we're exposing them to things that are potentially unpleasant, uncomfortable, painful, whatever word you want to use. They probably can all be used interchangeably. But I really think, as people learn ACT, they realize, I was really hesitant to take someone far enough and expose them to pain in a way that would help them change their relationship to it. Because as you mentioned, we can talk about pain, and we can talk about the theory, right? We can talk about, okay, if you start to, like, you know, play with pain and kind of bump up against it and brush up against it a little bit, that over time it'll probably change or you'll change. But unless you begin to do that.
Yes, that's it. You actually have to do it.
You have to do it. That's right.
Yeah.
It's kind of like saying, well, if you lift weights twice a week, you're going to build muscle. And here's how you do it. You do 3 sets of 10 at 75% maximal capacity, and with 2-minute breaks in between. And then you make sure you eat enough protein. And we can talk about that all day long, but you actually have to take action to do it.
You have to do it.
To do it. And pain's the same way, right?
Yes, definitely.
Yeah.
And you have to be a bit fearless, don't you? So
a couple more questions as we're coming to the end here. We've talked a lot about pain neuroscience education. We've talked about cognitive functional therapy. We talked about acceptance and commitment therapy. You've studied all three, and you're kind of weaving those all together, which is rare. So I want to, you know, just commend you for doing all that, because it's not necessarily easy to take those theories and blend all three together. It takes a very, I think, special individual to blend things. It's a lot easier to say, I'm just going to go deep on one thing. This is what I do. And I'm only going to do this. But you've started that blending. But my question for you is, as a physiotherapist, why is it a radical idea to think that physiotherapists are using the mind and mental training skills for the treatment of chronic pain?
Yeah, that's a big question, isn't it? I think it kind of goes back to what we were saying at the start about that whole professional identity bit, that we do things to people to take away the pain. So the patient comes in, they lie on the couch, we do whatever we're doing with our hands. We might stick some needles in them, you know, stick on some heat, you know, give them a token exercise at the end. And of course, I don't think anyone does that anymore. Like, it's pretty bad physio in a way, but like, that would have been how I was trained back in the day, in fairness, before we had all of this information. But I still think that's what the general public expects, and it's often what referrers expect as well. So they'll say, I'll send you to the physio for some exercise, and I'm sure that's going to help your widespread persistent pain, your fibromyalgia. And you're like, it's just not that simple. You can't just exercise that away. Or a person might already be quite fit and still have, you know, widespread pain. So that's just not deep enough. And I think physios as well themselves, I suppose we ourselves are a bit fearful about going into that whole thinking about, asking about thoughts and emotions. That's something that CFT does challenge quite a bit as well. And in some of the research done by the CFT group, there's some really good work on that. Aoife Sinnott did some lovely work on looking at why physios are maybe afraid to ask about feelings and emotions and all of that kind of thing, and that we felt we didn't have anywhere to go with that. But definitely ACT does give you, as a physio, valid places to go with that information then, or valid ways to ask about it. Not that we're trying to be psychologists or anything, we're not. Like, if someone has an anxiety disorder, obviously I would refer on, but we can still work with thoughts and feelings about pain. I think that's very definitely in our wheelhouse. But why do people not expect us to? I think it just goes back to, so it's definitely how we've been seen all this time, that we do things to people to take away the pain. We don't ask about those kinds of questions. We don't work that way. So I think it's a mindset thing generally, I suppose. Does that answer? It's kind of a very vague answer. That's a bit of a vague answer.
I think it fits very well with where we are currently as a profession, and also gives people an idea of where we need to go as we move forward, both in research, but I think more importantly, in clinical practice and public awareness, which I want to talk about more and more. I mean, my entire podcast really is public awareness.
Yes.
But I want to talk more about it as, okay, how do we engage the public and referrers, as you mentioned, who have beliefs about what we do? How do we engage them with, hey, here's what we really do that helps people with pain?
Yeah.
And yes, exercise is a part of that. And the research proves that. Exercise and physical activity, along with the psychological component. So putting the brain and body together, putting the mind and body together, that's really what we do as a profession. I think that's key, because the best research points to that direction.
Definitely. Yeah, absolutely agree.
Mary, it's been great chatting with you today. Thank you so much for joining us on the podcast. Please tell everyone how they can learn more about you.
I'm not that active in social media so much anymore. I am on Twitter. So my Twitter handle is at MaryMG40. That's it. Then I'm contactable there if anybody wants to contact me. That's it. Thanks, Joe. I really enjoyed it. Thank you for having me.
Great. So we're going to include Mary's Twitter handle on the page so you can reach out to her. Make sure to share this episode with your colleagues who are combining pain neuroscience education, cognitive functional therapy, and acceptance and commitment therapy. They're out there. Mary and I know a bunch of them. I think they'll really benefit from this conversation and just learn first about those three interventions, how they're different, how they can be complementary, and how you can use it in clinical practice. I'm Dr. Joe Tatta. It's been a pleasure, and we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.